My great pleasure to introduce Barrett Katz, who is the Chief Medical Officer at GenSight Biologics, and his talk will be entitled, What We Have Done, What We Are Doing. And Barrett, let me tee you up here. There you go.
Delighted to be here. If I had been forewarned that I would follow Nancy, I'm not so sure I would have accepted. But it is what it is. Now listen, I'm going to give you a helicopter view. I want you to see what we've seen as a company. I want to share with you what we've been doing. And I want to share with you the results we have so far. And I want to preface my remarks by saying this is a marathon for all of us. This is not a sprint. And so let us remember we're at the beginning of this journey, nowhere near the end. We as a company address ultra-orphan diseases. Mitochondrial diseases, frankly, is first and foremost on our list. We've done 2 clinical trials for Leber disease, and the difference in the clinical trials are that in one, the visual loss was from 0 to 6 months for patients to be enrolled, and for the second, the protocol would be the same, except that the visual loss was from 6 to 12 months. As these studies were put together several years ago, of course, we've learned more and the world has changed. And so what we thought then is a little different than what we think now. And of course, now we're wondering, as Nancy said, when is the best time to capture successful intervention for the Leber patient? I want you to look at the chart on the right here. That is a high contrast ETDRS chart. It's the chart that you will see in your ophthalmologist's office when he or she turns down the lights and turns on the projector. It's very black letters against a very white background. It's what we use, generally speaking, to measure central acuity. But I add parenthetically, the world is not a black and white world. The world is much more like what we see in this room. There are areas and differences of grays. And so we're going to talk about this as we move on. In our subjects in this first clinical trial, what was called REVERSE, we had 37 subjects. They were young folks, as you would think, mostly male. Their visual acuities were assigned as they came in. The patients were randomized so that some were put in a treatment group to get drug in one eye, and in fact, a sham injection in the other eye. And what we found was that they were pretty similar coming in the one eye to the other. This drug that was used, it's a gene therapy drug with an adenovirus type 2 vector, very safe, remarkably safe, injected in the eye. And I would say to you that when you first hear about injections in the eye, you cringe, but I will tell you they're done with a needle that is so fine, most patients rarely complain of anything after such intervention. There were some side effects to these therapies, a little inflammation in the front of the eye and the back of the eye. When we sterilize the front of the eye to do the injection, what we use to sterilize the eye causes some inflammation of the cornea. But short story, this intervention, this gene therapy, remarkably safe. Okay, now we're going to talk about the results from this first trial that we looked at. And again, I want you to get the helicopter view. No one bit of information is overly compelling or convincing or valuable here. It's the totality of the picture that helps us and lets us decide where to go next. What we saw in this trial was that the temporal quadrant of the nerve fiber layer in the eye, where the papillomacular bundle lives, where the most important axons exist that subserve central fovea vision, there seemed to be protection of these nerve fibers from this drug, comparing the sham injection to the drug injection. Now, what's a sham injection? It's an injection in which the eye is prepared as though it were getting a real injection with topical anesthesia, a little bit of an injection in the subconj area, the outer part of the eye, speculum is put in, but a syringe without a needle is pressed against the eye. So that's the sham injection. That was our control in this study, for better or worse. Second observation to be made in this study, the retinal ganglion cells, which are those cells that are in fact most affected by Leber disease, the ganglion cell volume in the drug-treated eye was much more preserved than in the sham-treated eye. And so you might say, well, those two bits of information are very, very nice. They tell us that for bioanatomic markers, there may be an efficacy signal here from this novel gene therapy. And so that was what we saw in this study. Bioanatomic markers do not correlate with vision. You can have good vision, bad anatomy, bad vision, good anatomy, any mix you want. But nonetheless, when you see a change in these bioanatomic markers, remember that the OCT, which is a quick scan of the eye, is objectively measured, which means that the patient doesn't say, yes, I see this letter, or no, I don't see this letter. It's like getting an X-ray. The patient sits there, the procedure is done, the results are kicked out by the machine. Now let's look at something else in this study, visual improvement. Strangely enough, atypically, unexpectedly, both eyes, the sham-treated eye and the drug-treated eye in this trial improved. 0.2 logMAR units, that's about 10, 11 ETDRS letters. 2 lines of vision for Snellen acuity equivalent. Let me say it again. The drug-treated eye improved. Surprisingly, the sham-treated eye, which did not get drug, also improved. Now, these were very unexpected results. Is this signal? Is this noise? It certainly is counter to what we thought we knew about the natural history of this disease. In other words, these patients are followed for a year after their visual loss. We don't expect them to get better. And yet, our patients who had no drug treatment in the no drug eye got better. Could this be placebo effect? Could it be noise? We are not yet sure what this means, but we are forced to question our assumptions and say to ourselves, maybe there is a bilateral effect of this drug injected in one eye on the other eye. So that's just one of the possibilities, which takes a while to even begin to think about, because it's counterintuitive, and much of the world is counterintuitive. What else can we look at and make sense of what we saw in terms of acuities? Well, once you see this result, you've got to say, geez, what the hell does this mean? So you've got to go to the literature, talk to the clinicians, and talk to neuroscientists, other than the doctors who take care of these patients. And the neuroscientists say, gee, we come across this in our work. We do see effects in the untreated eye. And the scientists who do research in other optic neuropathies can tell you, well, I've got this experimental model. I treat one eye and I see something in the other eye. So maybe there's a possibility of a bilateral effect. We have seen it in the anti-VEGF world for macular edema, and it is something that the retina guys will talk about. What other results did we see from this reverse trial? In terms of visual fields, no significant difference between the drug-treated eye and the sham-treated eye. However, here's the showstopper. Contrast sensitivity. Well, what the hell is contrast sensitivity? Contrast sensitivity, many of you in the audience, myself included, will remember the old black and white TVs. On those old black and white TVs, if you turn down one of these knobs, if you turned it down, it got more and more gray to the point where you couldn't really discern anything in the picture. Look at this chart here. The top line is very, very black against a very white background. The line down is a little more gray. The line down below that is more gray still. The line below that is more gray still. And this is what contrast sensitivity looks for. In other words, it's very easy to recognize the V, R, S, K, D, R letters. It becomes more difficult to recognize the C, N, H, Z, O, K letters. And in fact, there are 3 lines below that one. But what we're measuring on this chart is the ability to discern low contrast changes of resolution. And frankly, for our population of labor patients, this is a much more meaningful real-world metric than going to your eye doctor, sitting in a darkened room, having that projector turned on, and looking at very black letters. What we saw in our study, this first phase 3, is that the contrast sensitivity was almost doubled in the eyes that had drug treatment. And that's a very encouraging sign. It is a recognized visual function. It's not a visual function most people are familiar with. Nonetheless, it's very real. We have other data to show you that there are different ways to look at this data and cut and slice it and say, wait a minute, these patients had a drug treatment, they gained 6 letters more than the sham eye. In some circumstances, if we look at the best treated eye versus the best sham eye, they gained 12 letters as opposed to 4 letters. There's all kinds of positive information in that study from which we can learn. In fact, one of the things we saw in the study was if the endpoint of that study had been eyes that reached the level of 2200 or better, the study would have met such a primary efficacy endpoint. Let me give you some summary statements here. In a study like this, in any clinical trial, we have a binary event. You choose a primary efficacy endpoint, you meet it, you get it, or you don't. But as we talked about, the world is not a black and white world, it's a gray world. And so you've got to dig into these studies to see what information might be there. We found in this study that drug-treated eyes were more likely to achieve a vision of 2200. We found statistically significant protection of the retinal ganglion cell and the temporal quadrant of the nerve fiber layer. We found that the contrast sensitivity of the drug-treated eye just about doubled. Again, what else did we see? For subjects with better acuity at entry, they did better. When the visual loss was for a shorter period of time, the subjects were more likely to do better. If we define responder rates differently, we can see a real signal here. But again, that was a reverse study. The second phase 3 trial, what we call Rescue, will be out in fourth quarter of this year, December, perhaps January. We're starting another trial called Reflect, in which there'll be bilateral treatment, and we're installing a control group in that study. I want to close with this comment. We're all in this together. Do not be disheartened or discouraged by any one study of any one drug. In fact, recognize that we are the beginning of this journey, and it is in fact a marathon. And while any one of these drugs will be successful or not in any one trial, I would say to you, do not get discouraged or disheartened. We are at the cutting edge of this science. No question but that this is the future of medicine. And hang in there with us, hang in with the studies, hang in with your doctors taking care of you, hang in with this wonderful group, and recognize that in the long term we will win this battle. Thank you very much.